Okay, well, good morning, everyone. Well, it's morning here in San Francisco in the United States, but afternoon in Cameroon and other places. Thanks for joining us all. Welcome to the Health for the World International Grand Rounds. We are excited to have Dr. Ramaswami, our guest faculty here at Health for the World, who've been kind enough to join us again after a few trials last year with issues with connection. So we're really thankful for that, Ramya. Dr. Ramaswami is a physician scientist at the National Institutes of Health, the National Cancer Institute. She is a specialist in HIV/AIDS malignancy research work and specifically an expert in the management of patients with Kaposi sarcoma, herpes virus associated diseases such as Kaposi sarcoma and multicentric Castleman disease and other HIV associated cancers. Her clinical and translational research is focused on developing novel diagnostic methods and therapeutic strategies for patients with HIV and cancer. And she also investigates ways to reduce cancer care disparities among people living with HIV within the United States and beyond. So such a pertinent topic for our international audience, of course. So once again, thank you very much, Ramya. We are really excited that we're able to have you with us and meet with our audience here and give it over to you, and then look forward to the Q&A at the end.
Yeah. Yes, indeed. So excited to finally connect with you all, and this is the topic that's obviously my life's work right now. But I hope that in the time that I have with you, you'll get to understand why it's such an important topic and how there are so many disciplines that are involved in caring for people living with HIV and cancer. And perhaps, wherever you are, whatever your training is, whatever you hope to do, that you can yourself contribute in some small way to the care of patients who have both HIV and cancer. So thank you once again to everyone, especially to Elliot, to help set this up for us. Really so delightful to connect with the Health for the World faculty and team. Okay, so the point of the discussion I'd like to have with you all today is really to learn more about the types of cancer among people living with HIV. To really kind of understand the pathogenesis, how people present with this condition, and really understand what the delineation is between what is known to be the AIDS-defining cancers versus the non-AIDS-defining cancers, and then really broadly talk about the management of these conditions and how a multidisciplinary team approach is really important for a successful outcome among patients with these diagnoses. So we're almost coming to the 40-year anniversary of the identification of HIV as the cause of AIDS. It was a difficult time within the United States and worldwide, and continues to be an issue among countries around the world where access to HIV therapy is difficult. The seminal point where the identification of HIV came about was actually with cancer. So young men who had sex with men were developing Kaposi sarcoma, and that was the impetus to understand why do these young men who are otherwise well in themselves, had no prior medical history, why did they suddenly emerge with an immunodeficient condition predisposing them to cancers that they should not have? So cancer and HIV actually have a very, very close-knit history together, and actually many of the cancer developments that have happened have been on the back of HIV successes. So, and likewise, HIV has learned a lot from cancer care from the point of view of clinical trial development, ensuring that medicines are available quickly for this population. So overall, this has been a very, very important relationship that has happened. And so where are we now with the management of HIV globally? Well, in 2016, just 4 years ago, there were still 36.7 million people living with HIV worldwide. And you'll hear me say living with HIV because right now we don't say that people are dying from AIDS, at least within the developed world, because of access to care and access to therapy. So the term people living with HIV is very much a term that has been promoted by HIV advocates, and rather than saying HIV or AIDS patients, we prefer the term people living with HIV. Now, with respect to getting treatment for HIV, that continues over time, as you can see, to increase, particularly with some of the programs that have been developed from countries like the US and the UK to help access in areas like sub-Saharan Africa. And I know that there are initiatives within those countries as well to improve access to HIV care internally as well. So within the United States, however, we have a population of about 1.2 to 1.5 million people diagnosed with HIV, and this is a population that actually predominates in the southern states, as you can see on this map. Currently, I live around here, and the red highlights what the density is of new HIV cases. This is in 2015. I have to say that a lot of this doesn't change over time, and the issues around the new cases of HIV are a lot to do with, again, access to healthcare, access to HIV medicines, and so this is the area within the US that predominates and has high levels of HIV cases. And then, because for our Cameroonian audience, I pulled up as well the number of people living with HIV over time. And so you can see that since 2010 has been largely the same, about 0.5 million, about 500,000 people living with HIV from the UNAIDS estimate. And I'd be interested to hear how our colleagues in Cameroon see this as well. So broadly speaking, when we talk about cancers among people living with HIV, again, we think about the historical cancers that emerged with the identification of HIV itself. And so we broadly consider those cancers as AIDS-defining malignancies. So among those, you have Kaposi sarcoma, non-Hodgkin lymphomas, primary central nervous system or primary CNS lymphoma, and cervical cancer. And so historically, what has the definition of an AIDS-defining malignancy has been among people who have a CD4 count less than 200. Among other malignancies where CD4 count is higher, and so there's a healthy immune system otherwise, we say that patients have a non-AIDS defining malignancy in those cases. And so this can be any cancer, lung cancer, liver cancer, anal cancer, can emerge among people with higher CD4 counts, and any cancer can. And so those are termed non-AIDS defining cancers. Is this helpful? It is and it isn't. It is in that sense that, technically speaking, someone who develops Kaposi sarcoma has an AIDS-defining malignancy. But largely speaking, though, it isn't helpful because there are patients who have cervical cancer or Kaposi sarcoma who have higher CD4 counts. So are they technically AIDS-defining? Probably not. So it's a very broad terminology, and I don't think that speaking to patients, it's not that helpful to say you have an AIDS-defining malignancy. I think more importantly, it's a delineation that one makes in terms of understanding the immune regulation and the immune component in helping patients and identifying treatments. So we generally have this classification, but how useful it is actually out for question, especially now when, you know, you can give antiretroviral therapy and see some benefit, particularly with diseases like Kaposi sarcoma. And I'll go on to talk about that when we get to that stage. When we look over time, and if we continue to delineate between AIDS-defining and non-AIDS-defining cancers, we can see that over time on this graph, we see a drop in the rates of these AIDS-defining cancers. So you see a drop in non-Hodgkin lymphoma, the rates of Kaposi's and cervical cancer, with projections into 2030 that they will drop right down compared to the beginning of the century. Non-AIDS defining cancers, however, are actually quite stagnant. And as you can see here, we expect a plateau in many of these cancers over time. So why is there such a difference? Well, again, it's a lot to do with how the immune system regulates or the onset of these cancers and regulates the response to treatment. Kaposi sarcoma and some of the non-Hodgkin lymphomas technically arise in lower CD4 counts because of, you know, the effect of immune dysregulation in the body when patients get exposed to HIV. And so now with antiretroviral therapy, with emergence of improved immune systems, we will start to see declining rates of these cancers. And then similarly with age as well, what we see here, again, the delineation between AIDS defining and non-AIDS defining, which is in the green versus black and gray, we see a decrease over time of the non-AIDS, of the AIDS defining cancers. And actually, when you look at the older patients, we see as patients are surviving their HIV diagnosis, and then subsequently, much like cancer is a disease which happens as we get older, we see a larger proportion projected of more non-AIDS defining conditions among older people. So that's this green bar here that is much higher than at the beginning of the century. So what we need to plan for is that as people living with HIV get older, they are going to be more susceptible to developing cancers over time. So we as a group of oncologists need to plan for that in the future. So why does cancer occur among people living with HIV? Well, it's pretty multifactorial, actually. We talked a little earlier about the effect of immune dysregulation, the impact of this, the presence of a virus that is chronically activating the immune system and causing some dysregulation of the immune system, but also there's a deficit as a result of HIV. We also see these patients have risk of other chronic viral infections, and I'll talk a little bit about ABV and KSHV, but they're also exposed to other viruses like hepatitis B, C, and HPV. Now, many of these viruses, thankfully, we're introducing a lot of vaccine programs, but it's going to take many, many decades to see the effects of that. And then, you know, many of our patients do have a personal history of smoking, so that also predisposes to lung cancers, and aging itself, which is not on here, also contributes a significant risk to development of cancers. So what do we do about the HIV? And so HIV is you know, a standard treatment, and one can argue that cancer treatment among people living with HIV is probably further back than HIV treatment, which, you know, patients get the most up-to-date treatment. So treatment, as I'm sure many of you know, consists of antiretroviral therapy, and these are the different classes of agents that we use for treatment of HIV. And usually the the treatment of HIV consists of often one pill once a day unless patients have a history of resistance. And the one pill once a day often consists of three drugs from at least two classes that are shown here. And now most patients are on an integrase inhibitor backbone, and that seems to control HIV very well. Usually the most important thing with managing people living with HIV and cancer is thinking about interactions with HIV treatment. And older antiretroviral therapy, particularly those that are protease inhibitors, do have a propensity to interact with some of the chemotherapies and some of the newer targeted therapies. And so it's really important to think about how the HIV treatment may interact with the cancer therapy. However, it is really important to continue the HIV treatment throughout the cancer therapy, because HIV itself is kind of contributing to the onset of cancer. And so treating the HIV itself is really important. So under no circumstances really should HIV treatment be stopped, because there are a lot of options for changing regimens, and there are a lot of treatment options for HIV. So there should be a way to work around any cancer treatment that is being planned for a patient with HIV. So I'll talk a little bit about this as we go on, but the cancer care among people living with HIV needs to be multidisciplinary wherever possible. So our group consists of oncologists who are also hematologists. We have infectious disease specialists. We have nurses and other allied members, such as our patient care coordinator, occupational therapist, physical therapist. They will work together, and these are really difficult diagnoses to make in patients who are already quite unwell sometimes. And so working together, figuring out the diagnosis and the treatment strategies become really important, and it's not possible without a team of really invested individuals. So I'm going to spend the next few minutes really talking about Kaposi sarcoma, because I think it's a fascinating virus, and I hope you guys will agree. So Kaposi sarcoma herpes virus is the 8th herpes virus. It's a DNA virus, and it causes 3 conditions. So the first one that everyone knows about is Kaposi sarcoma, and we talked a little bit about how it was found at the early stages of the HIV epidemic. Multicentric Castleman's disease, and this is a PET scan of a patient as well as a CT scan of a patient. The spleen should not be this size, and this patient has multiple avid lymph nodes. This is where the virus itself attacks B cells, and it manifests within lymph nodes in patients, causing fevers, night sweats, pancytopenia. So this is a very severe condition that can actually manifest as multi-organ dysfunction if it's not appropriately found. And we'll talk a little bit about that. Primary effusion lymphoma is a type of B-cell lymphoma. And you can see an effusion here in this patient's CT scan. So this is where the virus leads to a monoclonal process causing a type of lymphoma in the patient's pleural cavity and pleural space. There can actually be extracavitary forms of primary effusion lymphoma, which sounds a little like an oxymoron, but you can see patients who present with masses, much like other types of lymphoma, and unless you look for human herpes virus 8 or KSHV, you won't be able to properly diagnose it. So the treatment for these conditions are very different, and we'll talk a little bit about that as we go through. So Kaposi sarcoma, to start off with, is where the KSHV virus, or HHV8, I'm going to mention it as KSHV, actually infects endothelial cells. And endothelial cells you find everywhere, so they can affect the mouth, the skin. It's predominantly the skin, but they can affect any organ in the body. This can be visceral, cutaneous, and even bone manifestations. And there are 4 epidemiological subtypes, but it's part of the same disease process. And among people living with HIV, this is one of the most common malignancies, and my colleagues over in Cameroon may have seen this quite frequently. For physicians in the US, you may see 1 or 2 patients if you're in a metropolitan area, but it's often seen very infrequently, and sometimes I have colleagues in oncology who are still surprised that people see Kaposi sarcoma in the US, but it does exist, and it occurs among people living with HIV at any CD4 count, as we mentioned a little before. So again, just for our colleagues in Cameroon, prostate cancer, this is the IARC website. And prostate cancer is one of the highest in Cameroon, and Kaposi sarcoma is around here. So it's not as common, but it is prevalent in Cameroon. So these are some of the lesions that you can see on the skin. So it technically are dark lesions. It can sometimes be mistaken for things, for other skin manifestations, other infections. But unless you take a biopsy and your pathologist knows what they're looking for, it's quite hard to diagnose. So oftentimes you see a spectrum of manifestations. You can see some flat lesions, and these are bumpy raised lesions. They're called nodular lesions. They're very active. And oftentimes lesions like this can fungate and cause problems. And so lesions like this on the foot can cause a lot of pain. They can occur with a lot of edema overlying the lower limbs as well. And particularly in the oral cavity and the GI tract, patients can present with a lot of difficulty swallowing, weight loss. So it's a pretty bad condition. And as I said earlier, there are 4 epidemiological subtypes of Kaposi sarcoma. The classic form occurred when Dr. Kaposi initially described this condition in the 1800s. This was among elderly Mediterranean men. The epidemic form, as we discussed earlier, occurs among people living with HIV. The endemic form is seen among people from sub-Saharan Africa, because KSHV, much like EBV is for most of the world, is found in an endemic form in parts of sub-Saharan Africa. And also iatrogenic forms are seen among those who have a renal transplant. So we see it in patients who have transplantation, and KSHV diseases manifest as a result of that. And as I mentioned earlier, this can occur on skin, lymph nodes, GI tract, and respiratory systems. And you can see it can occur with pretty profound infiltrates, causing pulmonary dysfunction and even respiratory failure, unfortunately. Unless patients experience symptoms, we don't always go in and endoscope and do a bronchoscope on every patient. It really depends on symptoms, because irrespective of where the KS is, the treatment is actually very much the same, and I'll talk a little bit about that as well. So some of our oncologists in the crowd may have seen the TNM staging for cancers. We use the TIS staging for KS. And this is where the tumor is, if it's confined to the skin. If it's extensive and there's oral disease or KS in the GI tract and a lot of edema, this is higher stage. If the CD4 count is lower than 150, it's also poor risk. And if they have any B symptoms, like fevers and night sweats and weight loss, you have to think of concurrent diseases like Castleman's in tandem with KS, but this can also be of a poor risk as well. The treatment for Kaposi sarcoma really is definitely antiretroviral therapy among people who have a diagnosis of HIV. Sometimes when someone's newly diagnosed with HIV and they start their ART, they've got a little bit of chaos on their skin, just a couple of little nodules or a couple of, one lesion that's looking a little benign. a bit of starting the antiretroviral therapy can really just get rid of that right away. However, in some patients who have extensive lung disease or fungating lesions, antiretroviral therapy is important and essential, but it can't be done alone. And so that's when you need adjunctive systemic chemotherapy, especially when you're just starting a patient on antiretroviral therapy, because people can get immune reconstitution. And so this phenomenon of KS-iris, one has to think really carefully about that, but it can cause pretty significant mortality in the literature, and it's really important to give chemotherapy alongside antiretroviral therapy when you're dealing with patients who have a lot more KS burden. There's really, unfortunately, no role for local therapies like pan-retin gel. Surgery is really not a good idea. You know, don't amputate a patient who has leg KS. They're gonna live a long time with their HIV, and you've basically disabled them. So there's no role for surgery. Radiotherapy, you know, unless there is a laryngeal KS that's causing obstruction of the lungs, I don't think there is any role for radiation therapy, especially on large areas of skin. You know, we have seen patients who experience really severe cellulitis. Some may argue that really bad fungating lesions like this toe should have radiotherapy, and I think that's a difficult decision to make. But, you know, in this patient who had this lesion, eventually did go away with chemotherapy. So there is, you know, systemic therapy, although it takes longer, may be more beneficial and prevent longer term complications of radiotherapy like cellulitis, breakdown of the skin, etc. So we had the emergence of pomalidomide as a study that was developed at the NCI. It's been the first drug that was approved since '97, so that just was approved by the FDA. There is the ongoing plan to develop a study in sub-Saharan Africa run by the AIDS Malignancy Consortium, which we're all very excited about. We saw 71% response rates in our cohort of patients. And the main thing to really think about with this agent is that patients do get cytopenias, blood clots, and you know, the birth defects associated with the immunomodulatory drugs is really important to take into account. The treatment of KS takes a lot of time. This figure shows a patient who had 6 cycles of chemotherapy, and then 5 years later the lesions went away. This was someone who was diagnosed with HIV and had KS at the same time, but it takes time. And the caveat to KS management is there's no set number of cycles. You tend to go until there's a plateau in benefit or no response. We don't use the term metastatic in KS management. Again, it's caused by a virus. You can never eradicate the herpes virus, but you can certainly treat and get rid of the skin lesions. So just to talk a little bit about Castleman's disease, we talked about how this was a B cell, it's a lymphoproliferative agent, disorder, so it's a polyclonal B cell process. It occurs among people living with HIV predominantly in the KSHP positive sense. It can actually occur at the same time as KS. So it can be quite confusing when you have someone who has newly diagnosed HIV, they have KS, they're having fevers and night sweats, and they're pancytopenic. And a lot of the time, the tendency is to think that this is all probably HIV, but unless you look for Castleman's, you're not going to find it. And it can actually cause a lot of morbidity and mortality even. So this is a patient who had a massive spleen, and we actually have, unfortunately, a patient in the ICU who's very unwell with massive splenomegaly. He has extreme edema and has multi-organ dysfunction. This study that we published back in 2014 has shown that, you know, patients have low albumin, low hemoglobin, low platelets, and low sodium. the HIV is often relatively well controlled, and this can happen at higher CD4 counts. So patients can be well controlled on their HIV point of view, but still manifest with Castleman's. And it's a waxing and waning condition. So it kind of comes, someone will think, oh, this is someone who has an infection, treat the infection, it goes away, and then it comes back. And it's every time they come in, they're really, really unwell. And again, unless you look for Castleman's, you're not going to find it because you need a lymph node to confirm the diagnosis. So again, imaging is helpful. You'll see a large spleen. You'll see lymph nodes that are avid on a PET if you can get a PET. But CT is really helpful at identifying lymph nodes. I also want to talk a little bit about its underdiagnosis, because again, you know, unless you look for it, you won't find it. And my colleagues did this fascinating study where they looked at patients who were from South Africa who were being ruled out for TB. So they had 675 patients, and they excluded patients who had a diagnosis of TB, but they were being worked up for TB. And it turned out that looking at these patients, the KSHV levels, so the HHV KSHV levels in the blood were really high. And this actually correlated with the presence of either another KSHV disease, which was not found. So if, the group 4 patients were those who had microbiologically proven without co-infection, and we can see that these guys actually had a really high KSHV level. So it might be that KSHV itself, you know, helps delineate whether there are presence of conditions like Castleman's, and if it's something that you can order at your institution, it would be very helpful for patients. These are all IL-6 syndromes, so the presence of pancytopenia, multi-organ dysfunction is because of high IL-6. This is a study from Malawi, from Satish Gopal and colleagues, which showed that MCD is underdiagnosed, and this is a small study of 6 NCD patients, but you can see how abysmal the prognosis is for patients in Malawi who are diagnosed compared to non-Hodgkin lymphoma or KS. And so it's underdiagnosed, and it's very difficult to treat in sub-Saharan Africa because of lack of access to rituximab. So rituximab has changed the way we manage MCD in the West. And this is our cohort of patients who were treated with rituximab predominantly in a study of a natural history study of about 62 patients. Our 5-year survival rate was 80%. And it's important to mention that some of these patients may have KS, they may also have primary effusion lymphoma. So diagnosis, understanding the disease, and treating it appropriately becomes really important in looking at the difference between survival in these patients. Then, broadly speaking, there are different types of HIV lymphoma. Many of them are caused by EBV as well, co-infection with EBV, and you can see primary effusion lymphoma here is caused by both EBV and KSHV. The prognosis for this condition is relatively okay, provided, again, you can get to an institution where they can treat you appropriately. The treatment for HIV-associated lymphoma is multi-agent chemotherapy. And this is usually with CHOP, which is a standard treatment for lymphoma, or EPOC. And there has been a pooled study of all the HIV-associated lymphoma patients, DLBCL, and they actually looked to see whether CHOP versus EPOC was better. And actually EPOC, which is CHOP with etoposide, which is given dose adjusted, so it's given over 5 days rather than 1 day, may be superior to CHOP itself. And so you can see this is R-CHOP, this is EPOC, so this may actually be better. But the problem is this is not a prospective randomized controlled trial, and so the jury is out for most of the other types of lymphoma, for HIV negative lymphoma, but for HIV positive lymphoma, this is our preference in our institution. And rituximab is a safe an effective anti-CD20 drug and should be used among people living with HIV. I think it's really important to note as well that many of these studies unfortunately don't include people living with HIV, and so the cancer knowledge and cancer care sort of lags behind until someone includes people living with HIV in the studies. And this again highlights that issue. Brentuximab, which is an anti-CD30 monoclonal antibody, was used recently in a publication in the New England Journal of Medicine for Hodgkin lymphoma, but that study did not include people living with HIV. So this is a separate study that was done just among people living with HIV, and it actually showed that the addition of brentuximab, this is just patients who had brentuximab with AVD chemotherapy, does lead to better survival rates. This is not a comparison. This is among patients who have higher stage disease. And so the response rates at 2 years was 90% overall survival and PFS of 87%. When they compared this to the patients who had HIV negative Hodgkin lymphoma, they found that people living with HIV and Hodgkin lymphoma in this study actually had more neutropenia and pancytopenia. But actually the drug itself helped to increase the CD4 count, which is a good thing because chemotherapy historically drops the CD4 count and it can predispose patients to infections. So if you've got an agent that can increase the CD4 count, it actually might help the patient too in the long run to prevent infections, especially when chemotherapy can cause infections, predispose you. I'm going to talk briefly about the non-AIDS defining malignancies and just checking the time. Yeah, we've got some time. So, so just briefly, you know, the main message to talk to you about these cancers is that, you know, the management of these malignancies should be the same irrespective of whether you have HIV or not. I think that the main issue is to make sure that the antiretroviral therapy is continued, and we talked a little bit about that at the beginning, making sure that you adjust for any potential interactions with antiretroviral therapy. And by now you know what are the non-AIDS defining malignancies, and I've listed them here. So HPV cancers, as many of you know, the HPV vaccine is very much in the forefront of the management and the longer term management of HPV related cancers. But right now we're still in the phase of figuring out what to do if you have high grade squamous intraepithelial lesions that are predisposing you to the onset of anal cancer. And so there is the ANCHOR study, which has been developed within the US. It's a prospective randomized clinical trial looking at how to best manage patients who have high-grade HSIL. And whether we should watch them versus intervene. So the jury is out about what to do in people living with HIV with this condition. And so the ANCHOR study is going to help answer this question. Because these patients are already predisposed, what should we do about them? So I can't say that I have an answer just right now on this. With respect to hepatocellular carcinoma in people living with HIV, again, this goes back to the issues that predispose patients. And so things like chronic hepatitis B, hepatitis C do play a significant role for the onset of HCC. And so it's really important that, again, following guidelines wherever feasible is important. Usually, in our practice, what we do is we do an ultrasound every 6 months in patients who have both HIV and HBV co-infection. And a lot of the antiretroviral therapy will co-treat the HBV infection as well. So it's important to follow that up, ensure that you're sticking to the guidance on that. And then, you know, with respect to lung cancer, this study in the Lancet Oncology in 2012, again, shows that patients who are HIV infected versus those who are not have pretty much the similar survival irrespective of their stage of lung cancer. Again, it's important that people with this diagnosis are treated the same as if they are HIV uninfected, but a lot of work has come through from Geeta Suneja, our colleague, who has shown that unfortunately people living with HIV are less likely to receive treatment for their lung cancer. And so, you know, how would you manage lung cancer? Again, the caveat, the bottom line is you think of them, you know, irrespective of their HIV, and treat them as you would per your guidelines for lung cancer. And then finally, just to talk about immunotherapy, because that's pretty, it's a pretty hot topic. You know, there are several cancers where immunotherapy is approved, is FDA approved. But again, unfortunately, even this study that came out in the New England Journal a few months ago excluded people living with HIV, which is extremely frustrating because HCC, as we just talked about, occurs very commonly among this group. And it's something that people die from very easily. And so looking at new treatment options is certainly helpful, but excluding patients from clinical trials is extremely frustrating. And now there's guidance from the FDA on how to write clinical trials that can better include people living with HIV. So despite many of these cancers including immunotherapy within their guidance, you know, the thing is that it's not necessarily licensed in people living with HIV, but the caveat still stands that you should treat them with immunotherapy. The worry with immunotherapy in this population was that people were worried that if immunotherapy, which uses the T cells of patients to fight cancer, if you had HIV, are you effectively increasing your HIV reservoir? Are you going to make it worse? Actually, there's a lot of data in the HIV literature for use of immunotherapy to cure HIV. Why is that? Well, you know, if you look at the T cells in someone with HIV, and you look at the antigen stimulation from HIV, the T cells are actually pretty exhausted. Add in cancer and they get even more exhausted. And so what that means is giving them immunotherapy actually helps activate and kind of reduce the exhaustion that occurs from HIV. And so they can better identify some of the viruses that help, that actually, you know, help the immune system hide the cancer. So KSHV, for example, has these markers that downregulate some of the immune markers that would ordinarily help the immune system find the cancer and address the cancer. So by giving immunotherapy, you're helping to reverse that. So immunotherapy may actually make sense in people living with HIV. And this is from a recently published review that came out a couple of days ago from our group. And we actually did the first prospective phase 1 study of pembrolizumab among people living with HIV. And so we showed that CD4 counts, and this is, we looked at immunotherapy in different CD4 counts, and we actually found that it was safe and there were no additional immune adverse effects. And, you know, there was some benefit seen. And we, again, saw an increase in CD4 count in some patients at the lowest CD4 count between 100 and 200. And that's actually, 200 and 250. And that's actually beneficial for patients, again, less likelihood of a really severe infection from chemotherapy. So just to summarize again, you know, there are cancer disparities that have evolved over time among people living with HIV, and I'm hopeful that over time we'll be better at kind of reversing these issues, and you know that the treatment should be the same irrespective of your HIV status. It shouldn't be a reason to withhold or stop treatment. And then the management of cancer among people living with HIV should be multidisciplinary. And that's pretty much it for me. And this is our team. So this is our team of my amazing colleagues who help care for our patients that come to Bethesda, Maryland. So with that, I'm going to open up for any questions from you guys.
Thank you so much, Dr. Ramaswamy. I sincerely appreciated that. I'm based in Tennessee, and we have a relatively high HIV burden. So it was very nice to learn about that. Thank you so much.
Send them to us if we can be helpful.
Absolutely.
I would love to say that to our colleagues and friends in Cameroon, but right now it might be a little tricky.
Yeah. And now we can field any questions from Cameroon.
I have a question for our colleagues in Cameroon. If they see a lot of Kaposi sarcoma or cancers in people living with HIV.
Hi. Hello? Hello, can you hear me?
Yes, we can hear you. Thank you.
Hi, Dr. Ramaswamy. Thank you very much.
You're very welcome.
Okay, I'm Albert. So we want to thank you very much. We really appreciate the topic. It is really very relevant for us here in Africa, especially in sub-Saharan Africa. In Cameroon, we are located in sub-Saharan Africa. So this is something that is really relevant to us. We see this a lot in our practice, HIV. Well, it is said that Africa has close to maybe just about maybe 20% of the world's population, but we have more than maybe close to 7% of the HIV. So this is something that we deal with on a daily basis. So thank you very much. Quite a relevant topic to us here. So we do see a lot of these patients, and definitely we see a lot of Kaposi sarcoma. Right now, I think we have about maybe 2 or 3 patients with visceral KS on the ward. And I really did want to ask you about the diagnosis. I came in a little bit late, and I don't know if you mentioned it. Because in our setting here, we have lots of pulmonary diseases in these patients with HIV, especially those with advanced disease. We have tuberculosis, we have things like fungal infections, we have PJP, histoplasmosis, and things like that. So we have all of these constellation of chest infections that can happen in these patients with severe immunosuppression from HIV infection. So sometimes it becomes a challenge actually to make a diagnosis of something like visceral KS. Now the cutaneous manifestations can help us, and they do a lot, but sometimes we know in about 10% of these patients, they can have visceral involvement without any cutaneous involvement. So then I'm just wondering, what would be your take on this? How about something like bronchoscopy? Because that is something that we have thought about sometime. Because we have these chest x-rays in these patients, and we know that for something like Kaposi sarcoma, then you're expecting hilar adenopathy, mediastinal adenopathy with a little bit of perihilar infiltrates, as opposed to the PJP where you want to see this diffuse interstitial infiltrative pattern on the chest x-ray. CT scans, we do have them, we can do that, but then again, not very specific findings. So how about something like bronchoscopy, just visualization of the published lesions if you do bronchoscopy? What do you think about that?
You raise a really important point. And, you know, I think that with respect to pulmonary KS, it is such a severe visceral manifestation because it's the lungs. And so identifying the pulmonary KS, you can certainly do bronchoscopy, but the problem is if you've got end bronchial KS, you're not going to see it on the in the bronchoscopy, because you'll see some reticular nodular shapes on the CT, and then when you go down to look, you may not see what you want to see. So bronchoscopy is really only helpful if you're suspecting large airway disease, because otherwise you're not going to see it. But, you know, I think that if you have someone with a pleural effusion, or I would probably, what I would do in a case where you're thinking they have PJP and you've got other infections and you may be thinking of KS, I would treat it. I would treat everything, because unfortunately you will end up treating the PCP and they're still not better. And part of the treatment of PCP may be steroids. And so the steroids themselves can get the KS worse, because steroids cause immunosuppression and it can make KS worse. We see that all the time. So in cases like that, I would actually treat infection and treat KS. And yes, of course you can do a bronch, but a bronch is only going to help you visualize, because you can't do a biopsy because they'll bleed. So that's what I would suggest.
Okay. Yeah, thank you very much. The other challenge we have here is that we do not routinely do definitive diagnosis of things like PCP with the different stains, looking for the cyst forms and the vegetative forms. So yeah, it is a challenge.
It's a big challenge. Yeah, and I commend you for your efforts. It is extremely hard. And oftentimes I think, you know, looking for things, concurrent diseases like Castleman's or lymphoma becomes even harder, because you have to chase after a lymph node and your pathologist might not see it. You may have to do telepathology. So it's incredibly difficult.
Yeah, thank you very much. We want to appreciate you doing this work.
Yeah, and I'm here if there's anything you guys need. If I can be helpful, of course, feel free to reach out.
No problem.
Thank you, Dr. Ramaswami. We have a question from the audience. They wanted to know about your experience in treating cervical cancer in patients who have HIV. They noticed that they are seeing it in a particularly young age group, between the ages of 25 to 30.
Yeah, the thing about cervical cancer, I mean, we don't treat as much cervical cancer within our group. I mean, the thing is that, yes, you're likely to see it in younger populations. There was a study that just came out in the Lancet about breast cancer in sub-Saharan Africa, and they actually found that those who had HIV within that study were much younger than other patients, and they had a higher mortality risk. And so it begs the question of whether the biology of this disease in those who have HIV is different from those who don't. With respect to cervical cancer, I would follow your local guidance. These patients are younger, so depending on the stage of their cancer, you should treat them as appropriately as you would for your country guidance. And I see that you have another question about pulmonary changes with antiretroviral drugs. So, I mean, antiretroviral therapy is relatively well tolerated. And if you're starting to get side effects, you have to wonder, is there a different pathology going on that you haven't identified? So we have patients who have KS, who have their ART, who are on ART, and suddenly they start vomiting. And you know, the natural tendency to think is to blame the antiretroviral therapy. But really what you should be thinking of is there a concurrent diagnosis? Like, is this patient got KS in their GI tract that is causing them to have nausea and vomiting? Do they have an infection that may be causing them to have breathing difficulties or GI symptoms? So I would say that I have not seen any pulmonary issues with ART. I'd be, you know, if you'd like to clarify your question so I can help answer it, I can certainly do that.
Okay. And while we're waiting on that, I have a question as well.
Yeah.
I know that you mentioned that some protease inhibitors can have interactions with chemotherapeutic regimens. And have you noticed that any specific protease inhibitor is more apt to do that, or
Yeah, so historically, things like cobicistat, the boosted regimens, things like ritonavir, those are the older chemotherapy regimens. So some of the sort of once a day pills in the sort of early 2010s, so things like Genvoya, for example, has cobicistat, and that is known to interact with a lot of antiretroviral therapies. And then there is tenofovir, which is a backbone for many antiretroviral therapies. Historically, we never use cisplatin, which is a very common chemotherapy agent. We don't use it with tenofovir because they both work through the kidneys. And so you've got an augmented effect of the tenofovir causing higher levels of cisplatin. And so you can actually precipitate, I've seen this in 1 or 2 patients, you can precipitate renal failure. But we have an HIV pharmacist, who I'm going to point out here, who basically helps us, Dr. George, helps us, plan the chemotherapies and try and avoid any potential interactions.
Thank you. Thank you.
No worries.
Let's see. I can ask another question as well. I find this very interesting. So when you mentioned Kaposi sarcoma, you mentioned that there's this kind of balance between doing monotherapy with antiretrovirals or combining them with chemotherapeutic regimens. Are you aware of any diagnostic criteria to help sway your decision in that, or is it just a clinical judgment?
Yeah, usually I think that the sort of yay or nay is the presence of any visceral disease. I think that once you're dealing with someone who has GI or pulmonary KS, like we were talking about, it's a no dispute. You must start some systemic therapy. The monotherapy question then becomes a little trickier if you've got just cutaneous KS. So if you've got just a couple of nodules on the skin, then it depends on where it is. So some people can get very symptomatic lesions on the base of their foot. And if it's one lesion, do you want to watch it or not? We actually were referred a patient from the NIAID team who has some KS on his foot, and he hasn't started antiretroviral therapy yet. So we're waiting to see the effect of that. But if it gets pretty symptomatic, or, and some individuals may feel that the appearance itself is stigmatizing. These are very visual lesions on the skin, and so some people may feel, I need to get rid of this, and so the only choice for them is to start some systemic therapy. And yeah, I mean, the antiretroviral therapy is going to take time to work, so you want to get in, and systemic therapy works pretty quickly. It starts working within 2 weeks, actually. Yeah.
Thank you so much for that. And thank you again for your time and your expertise. This was an excellent presentation. We truly do appreciate you.
Thank you so much for inviting me, and to my colleagues elsewhere, if please feel free to email me if I can be helpful to you. We're always happy to help consult on patients, and if we can be helpful.
Awesome. Thank you so much.
Thank you all.
That should conclude it.